Commissioners. Okay. Good evening, everyone. I would like to call to order this special meeting of the Board of Commissioners of Public Hospital District Number 2. It is a special board meeting because we will have 3 commissioners in attendance, a quorum. Thank you all for coming. And we are recording this meeting. Zoe Reese, Verdant's Director of Community Impact and Grant Making, will open this opioid crisis community roundtable. Again, we will be recording this meeting so that we can share it with the rest of our community. We will be posting it on our website as well. Zoe?
Thank you so much, Jim, and thank you all for coming. I am so pleased to have the opportunity to engage in a dialogue with the broader community and share some of the amazing work that is happening in South Snohomish County already. So thank you for coming. And the goals of this roundtable before we jump into the agenda is to provide awareness really around the growing epidemic of opioid use and overdose and the work that's happening in our community to address this issue. We are also hoping to reduce the stigma for those who are experiencing substance use disorders and to increase the likelihood that folks know where to and how to access treatment services if that's what they'd like to do. Our hope is to further share Verdant's belief that all of our community members deserve access to the tools and services that they need to stay alive. The agenda for this evening, if we can move to the next slide, is we'll quickly go over some definitions that you'll hear used in the video and potentially in some of the conversations. I will highlight or introduce the partners that you will see in that video. We will watch a 17-minute prepared video that highlights some of this work and the recent data coming out around Snohomish County specifically as it relates to overdose and use. We will talk about recent Narcan training and distribution that has happened in the community, and then move into some kind of FAQs as well as a Q&A with our esteemed panel of presenters here that will be open to community questions and dialogue. So very quickly, going through some of these terms, and this is a very cursory overview of these. We always recommend folks check out the SAMHSA, S-A-M-S-H-A website if you want to learn more about any of these terms. It's government agency that oversees a lot of this work. When we talk about substance use disorder, we're really talking about folks for whom the recurrent use of alcohol and or drugs causes clinically significant impairment, which can include health problems, disability, or failure to meet major responsibilities at work, school, or home. You may also hear something referred to as opiate use disorder, which is a subset of this. Harm reduction, which is a set of practical strategies and a philosophy that is aimed at reducing negative consequences associated with drug use. You'll hear a lot about opioids, a compound resembling opium and addictive properties or physiological effects. You might hear about the syringe service program. I actually know you'll hear about the syringe service program, or SSP, which is a community-based prevention and harm reduction program providing a range of services, including linkage to substance use disorder treatment and access to and disposal of sterile syringes and injection equipment. Medication-assisted treatment, or MAT, you may sometimes hear, is a harm reduction program involving the use of evidence-based FDA-approved medications to treat the symptoms of withdrawal and cravings for individuals with opiate use disorder. Trauma-informed care, an approach to care that acknowledges that healthcare organizations and care teams need to have a complete picture of a patient's life situation, past and present, in order to provide effective healthcare services. This is also a frame of moving away from asking what's wrong with you to asking what happens to you and helping people move forward. Detox, you'll hear about from our friends at Evergreen Recovery Centers, is a process or period in which one abstains from or rids the body of toxic or unhealthy substances. 2 of the programs we're going to be highlighting are folks that we have recently received Verdant funding and are doing some great work in our community. The first is Evergreen Recovery Center. There's a link here to their website. We've included their mission statement, and they focus on the underserved, low income, and homeless who have alcoholism and other drug addiction, addressing the whole person's needs. And Verdant has funded what is called a bidirectional integration program, wherein they are able to hire a primary care provider, who you will meet tonight, to incorporate physical health care into their substance use disorder services by adding a primary health care scope of services and medical interventions to the existing mental health and substance use services. So people can come in needing either service and get whatever they need. This program operates from their 2 Linwood locations and is made available to over 2,000 individuals annually and is available for walk-in and scheduled appointments. Next slide, please. You'll also hear from Sound Pathways. This is a recently rebranded name for Pacific Treatment Alternatives. You'll see here the link to their website and their mission statement that includes them providing wraparound social services to community members addicted to drugs and alcohol, with a focus on reducing harm to our community and creating safe pathways for individuals to find healthy solutions to their problems. And we will be highlighting the syringe service program, which Verdant has funded to expand into South County. And this is a program that provides needle exchange, one-to-one harm reduction services via street outreach to encampments in high-risk areas, as well as in-office services in their Everett-based clinic. They clean up syringes and debris in the public areas and bring harm reduction support, such as clean medical supplies, overdose reversal meds, referral to health and social services, with the goal of reducing death and disease. And in the first 6 months of this program, so the 6 months that just ended, they've already served 657 individuals in South Snohomish County. And I think from here, I'm going to hand it back over to you, Jim.
Yeah, thank you, Zoe. Good evening again, everyone. I'm Jim Distelhorst. I'm a retired family physician, and I'm the current president of Verdant's Board of Commissioners. We've put together a 17-minute video presentation that we will view shortly. During this video, we'll hear from 5 individuals. First, we have Jason Williams, a research scientist for the University of Washington's Addictions, Drug, and Alcohol Institute, ADAI. Jason will be going over the statistics, observations, and trends the team has found in their research at the Addictions, Drug, and Alcohol Institute. Then from Evergreen Recovery Center, we will hear from their CEO, Linda Grant, their Director of Health Services, Michelle Rutherford, and primary care provider, Andrew Diskowski, a naturopathic licensed physician. They'll be discussing the work that they do in their organization and the observations they have made throughout this opioid crisis. Lastly, we will hear from Sound Pathways Program Manager, Shannon Smith. She will detail the work they are doing, share client stories, and share the experiences she has had with those suffering from substance use disorders. Can we start the video, please?
It is a polysubstance phenomenon. It's several phenomena mixed together. So starting here with just overall death rates, the green line is what we're all concerned about, 10 years ago, even 6 years ago. Commonly prescribed opioids, oxy, pill mills, et cetera, et cetera. This was the whole, when I started on this work, was sort of the tail end of this, the opioid epidemic. That term was being used. And we saw deaths, the red line is any opioid deaths, start to kind of peak around 2009, 2010 and come down a little bit. Then people talk about sort of the second wave. Heroin starts to pick up because oxy's not as smokable. We've had prescription monitoring programs, other efforts to decrease supply or decrease illicit supply. So people switch to heroin, we start to see an increase in heroin deaths. And then we have this so-called third wave where the synthetic opioids start really taking off. And that is, to anybody who ever works with data, that's basically an exponential line. That is not a good thing in terms of since this is deaths, that is pretty scary to see that taking off like that. And so the result is, and again, this is just preliminary 2020 data. If anything, these numbers will probably go up once I have the finalized data, but that is just a huge increase year over year. Snohomish County, 5.7 deaths per 100,000 with heroin, 10.72 deaths per 100,000 residents with involving synthetic opioids. And this is deaths involving synthetic opioids, basically divided by residents times 100,000. So that's your common, just a gross rate. And the statewide rate is 5.52. So well above the statewide rate, basically second only to Yakima. I do most of the data in the background here, but I certainly pick up what we're pushing, and that is medications. That's what I know a lot of people are working on, is getting medications for opioid use disorder. People now recognize that we have to have naloxone circulating to keep people alive. If you provide safe supplies, you're building relationships. And I think that's a big part of getting people comfortable with coming into treatment, because you do hear about feeling like they're being lectured to rather than worked with. So you get a lot of resistance to treatment. So anything you can do to build up a trusting relationship so that when that person's ready, they can come to you and say, I need to stop, I need help.
I'm Linda Grant. I am the CEO at Evergreen Recovery Centers. And Evergreen Recovery Centers is a nonprofit corporation that's been serving Snohomish County since 1973. One of the things I wanted to report on is that our detox program, which has been in operation now for 4 years, and in those 4 years, we've seen over 3,500 people. And a good 20% of them have gone on into treatment and recovery. People come through our doors, they have multiple needs, and often getting someone to go to another facility, whether it's to a mental health facility or to a physical health facility, is not as easy as it might seem. So in order to give them the very best care, we often see that it would be to the advantage of the client to be served in one place, and often it is in the place where they are, and that may be our detox program, or it may be our LEAD program, which reaches people on the streets who are homeless, and the police have identified them for having needs. So we are aiming in our new project to address those issues along with the issues of our clients that are established in treatment, who have always, because they're low income, have transportation challenges, time challenges, and so we are bringing services to them in our Linwood outpatient office so that when they come in for the outpatient treatment group, they can go on over and visit with the primary healthcare provider or visit to have some psych med adjustment. The most common drugs are fentanyl, methamphetamine, And increasingly, we're seeing cocaine. The perception of the opioid crisis is the young teenage or young adult person, and we have to expand our thinking on how we address that. About 70% of the opioid overdose deaths are people who are over age 30. The work that we do in our detox is both to serve the person with withdrawal management, but also to address their long-term needs, including medications. And we see about 800 to 900 people a year coming through with an emergent situation, or they're preparing to go to residential treatment. And we provide a whole host of other services there. We're trying to fill gaps in the system and make sure that when somebody comes in our door, that they get the very best opportunity for recovery.
I am Michelle Rutherford. I am a psychiatric nurse practitioner. I work for Evergreen Recovery Centers, and I've been there about 4 years now. I have about 10 years of substance use disorder history working with patients. We've been asked to talk about some of the trends we've seen now and during COVID. Fentanyl is the primary opiate being used. You know, it used to be the rumor around for our patients was that you could never die from smoking an opiate, but now people are dying from smoking fentanyl. Nationally, there has been about a 20 to 30% increase in overdose deaths in the 12-month period between, I believe it was April 2020 to April 2021. We see all different ages, we see all different ethnicities and races, and people from different socioeconomic levels as well. It's really hard to decide, to pick who may have a substance use disorder.
I'm Andrew Jakowski. I'm a naturopathic primary care physician, licensed acupuncturist, and registered nurse. I have about a 5-year history in substance use disorder treatment as a nurse on an inpatient setting. I am now taking over the role of a primary care provider in the Evergreen Recovery Center's Health Services Department, as well as doing consultations in the inpatient centers. Normally, our patients would get services from either a primary care provider or they might get it from the ED or an urgent care. But oftentimes when they go to the primary care provider, they have 5-10 minutes. They see their chart, they see the history behind them, and then they're immediately like, okay, well, let's send you to another place, let's send you here and there. And with the substance use being a problem in their life, they don't really have time to go to different providers left and right, and oftentimes appointments get missed and they just neglect their health in general, or they'll go to the ED when things get very severe. What I've noticed in practice here is that a lot of patients come and they haven't seen a primary care provider in upwards to 10 or more years. They haven't taken care of their health, and a lot of their medical conditions are undiagnosed because they have not had them addressed, because their use has been a priority in their life, and housing and food and safety have become priority number one. So one of the things we're doing is we're doing a lot of imaging and diagnostics. We're doing a lot of evaluation and management. And we're working very closely with Project Access and other referral networks to try to get patients appropriate referrals and treatments that would help better serve them, but still having a warm handoff. So it's not like here's a referral, goodbye. And informing them of every step of the way. Another trend that we're seeing is that in COVID, there has been a much higher relapse rate, a lot more recurrence of use. And one of the things that we're striving to have is, regardless of whether or not you've relapsed or if you're in recovery, we want to be a safe place for people to feel they can come back to, regardless of their situation, without any judgment calls. And that's what we are doing. We have had a handful of patients, if not more, come to us in crisis and need, saying, I relapsed, I need to get back into detox, I don't know what to do. And their first thought and first stop was to come to health services for guidance. And so we're creating a safe, protected space for people to come at all stages of recovery, at all stages of life, and to help guide them into a safer environment with housing, counseling, therapy, medical management, and just a warm, loving touch.
Hi, I'm Shannon Smith, and I am the program manager for the Snohomish County Syringe Services Program. We cover the entire Snohomish County. We have some emphasis right now on South County. We have realized that the South County was not being serviced as much as it should. So a lot of our efforts were originally in the Everett and the North County, and we have seen an increase throughout the county. So we now have a team that specifically goes out to the South County. There's been a new branding that we have undergone recently. So the previous specific treatment alternatives is now under a new branding name of Sound Pathways. And along with that, we started looking at the syringe program, deciding, you know, what best serves the purpose of our clients. So previously it was the AIDS outreach / needle exchange. And since we do more than just needle exchanging, we had changed that to Snohomish County Syringe Services, because we provide services outside of just exchanging syringes. We're able to do outreach for 4 days a week with our team out there, as well as being available in the office 4 days a week. So we offer services 5 days a week throughout Snohomish County. Our team goes out and they do the outreach. We provide our clients with or one-to-one harm reduction. So we bring in their dirty needles and we provide them with clean needles. And we have some discretion. So we bring with us supplies for them to have, and then we also have with us any resource information they may need. So we have information about cold weather shelters. We have mental health services that we can provide them information for. We have areas for them to go to food banks. We also have with us wound care kits. We have cold weather supplies with us, blankets, lunches. We always have naloxone or Narcan on us. We'll have resources for them if they decide at that time they're ready to get clean or sober. We can help to set them up with referrals to detox agencies. We have a wonderful relationship with Swedish Hospital. We 100% recommend that our clients go to Swedish Edmonds for any services that they need. We're reaching clients that not only are that stereotypical, you know, what people like to say are the, you know, the addict that comes in and they're getting their syringes. We see people who are in areas like in Edmonds and Bothell and Mill Creek who have, you know, 40-hour-a-week jobs, who have families, who don't want to come into the exchange because of the stigma that's attached to it. So we will meet them at their residence or a place that they feel safe that they can, you know, exchange. So I think it's just really important that we identify that this is a disease, this is an epidemic that hits all areas and all different, you know, ethnicities, you know, races, economic statuses. I just want to share with a client success story that we had. We had a young gentleman, well, in his 30s, who had been, you know, drinking and using drugs throughout his life, and he came to a point where he was done. And before this, I would have never known to take him to the Swedish Edmonds Hospital, and I was able to connect him there with Swedish Edmonds, and they got him in, and they made him an appointment for Ideal Options and provided him with a prescription for 3 days worth of Suboxone. And from there, he was able to go to his appointment and get into Ideal Options. And you know, this is the amazing thing about how when the system works together and it all flows nicely. But when he was at Ideal Options, he met with one of the embedded social workers who was able to then help him with the process of getting into inpatient treatment. And then he got into the inpatient treatment, and then he was able to get into a clean and sober house. And he's been there now, and he's got like 4 months clean and sober. If he had not had somebody there who made that appointment for Ideal Options, who got him that prescription for Suboxone, he would have walked out that door and probably never moved forward. And this is how the collaboration with our agencies in this community make things work. You know, knowing that when you walk out of there, you're going to see somebody on the other side who's going to be there to help you. You know, to not do it for you, but to do it with you. We have a mom who was coming in on a regular basis, and she would be asking for some naloxone, and she'd probably come in like every other week. And so she had expressed to us that the reason I keep coming back in and getting naloxone is that I hope that someday my son will be alive when he's ready to get clean and sober, but if he's not alive, he will never have that opportunity. We're here to say, here's what you need right now, and then when you need this, we're here as well. And if that doesn't work, you come back, because we're still going to be here, you know, and eventually, you know, hopefully then they'll get the opportunity to get. For us to be out in the community is more important than ever now, and not just to provide them a service with bringing them some, you know, syringes or bringing them the clean supplies, but to meet people where they're at so that we can help them to stay healthy and stay safe, so when they're ready to get clean and sober, that we're available and they're alive to do so. You know, being able to get the naloxone and the Narcan out there. You know, we got people who have, you know, some serious wounds that if they don't get them taken care of, they're not going to be able to be here. So it's really important for us to stay out there in the community, and I'm finding more so now how much more important that is, especially with the stigma of coming in here.
Great. Thank you very much for all who participated in the video. We really appreciate it. Excellently done. Thank you. We also wanted to share with you this evening the Narcan trainings that Verdant hosted throughout the month of January. Narcan is a naloxone nasal spray. Once administered, this spray competitively blocks the effects of an opioid overdose. Sometimes more than one dose is needed. During the month of January, Verdant Health Commission partnered with Molina Healthcare and Snohomish County Human Services to host 3 free Narcan trainings to Snohomish County residents. These trainings were led by Amy Wheat, opioid outreach specialist for Snohomish County Human Services. We had 75 people participate. This means that there are now 75 more people in our community trained to recognize the signs of an overdose and administer Narcan. Furthermore, each participant was given a Narcan kit to take home. These kits were provided by Molina Healthcare. Each kit contains 2 Narcan nasal sprays. This means there are now 150 more of these Narcan nasal sprays circulating in the community. Verdant is also exploring offering additional trainings in the coming months. May I have the next slide, please? So here are some frequently asked questions. And we will, after this, we will begin our question and answer session. So what is the overdose rate for Snohomish County? In 2020, 525 people died of an overdose in Snohomish County. Snohomish County had the highest opioid death rate from 2018 to 2020, and the highest synthetic opioid death rate. What are the most common drugs? Fentanyl now is the most common drug. Methamphetamine is the second most common used drug. Are syringe services approved by the CDC? Yes. SSPs are approved by the CDC. They are also approved by the Department of Health. What are the benefits of syringe services? Syringe services reduce needle stick injuries, prevent the spread of HIV, and are proven to reduce overdose rates in areas in which they are implemented. Do syringe services hand out free needles? No. Syringe services exchange needles at a 1-for-1 rate. People are only provided the number of needles which they turn in. SSPs do not increase the number of needles circulating in society. Who has substance use disorder? People of all demographics may have a substance use disorder. There is no stereotype, as substance use disorders do not discriminate. Anyone may suffer from this disease. And now I would like to welcome Linda Grant, Michelle Rutherford, and Andrew Zakowski from Evergreen Recovery Center, Shannon Smith and Debbie Graham from Sound Pathways, who all have volunteered to help answer any questions you may have, and Jason Williams from the University of Washington's Addictions, Drug, and Alcohol Institute, all who have kindly agreed to serve as our expert panel for the Q&A discussion. To learn more about the work these organizations are doing, we have provided the links to each of their websites in this slide deck, which can be found on our website after this meeting at www.verdanthealth.org. The video can be found on our YouTube, which can be accessed along with our other social media platforms using the QR code provided. Thank you. Any questions?
And it looks like we have a hand raised from April.
Hi, this is April with Ideal Option. And I was just curious, I know that I previously worked for Evergreen and for the Diversion Center. And I know that when we were doing our rapid tests on when people first came in, we were seeing a large mixture with the methamphetamine use of PCP, fentanyl. Is this, and then various other drugs, and when they're claiming to only be using methamphetamine, is that still something that we're seeing?
This is Michelle Rutherford from Evergreen Recovery Centers. Yes, when we see people come in for detox, we're seeing varied results on their urinalysis. They will say, yeah, I've only used fentanyl, I only use methamphetamine, and we'll see benzos, we'll see PCP, we'll see MDMA. It's been very interesting, terrifying too, because there's polysubstance without people even realizing there's polysubstance at this point.
Right, and are you still seeing an uptick in the psychosis that it's creating?
Yes, yeah, we're seeing more and more psychosis, and with people who are just claiming to use fentanyl, but the methamphetamine has been creeping in.
Okay, and what are you guys specifically doing to when somebody does present with that level of psychosis and they have so many substances in there? What is the best way to treat and service that person while they're in psychosis?
So we can use medications to help manage the psychosis. A lot of times they do clear up by the time they leave detox, but if not, then we're referring them out either to follow up with us for, if it's not debilitating, or we're having them, we're referring them over to the hospital for more intensive care.
Are you seeing that the detox length is longer in these cases now? What is your average stay for detox, I guess?
So, yeah, average stay is still about 5 days, but we are seeing a need to go for further days. And it's mostly not for the psychosis, but it's more for the fentanyl. The fentanyl takes longer to leave the body. We're seeing that it is like living in the fat cells. And so it's releasing at all different times. So someone may be feeling better one day in detox, and the next day they're back into full withdrawal. So it's been really hard to manage. We've been having to change protocols frequently or look at new ways to do things, asking for more days from the insurance companies, requesting more days because the insurance companies will agree for a certain amount of time, and then they're needing more time. We also use Suboxone as our buprenorphine as our tool in detox for either taper or to do an induction. And we send them home with some of that as well, so that they have enough to kind of taper themselves off. But we're also finding some people want to stay on the Suboxone, and that's really wonderful, and we can do that for them too.
Thank you.
Of course, thank you.
We have a few questions in the chat. Jim, I don't know if you saw that.
Go ahead.
Just related to services for teens specifically, who is providing this level of service for teenagers?
I'm just going to
Okay, see,
respond.
One answer.
Oops.
Go ahead. The Center for Human Services offers outpatient treatment for teens was also in the chat. Does anyone else have a comment?
I know that North Point Recovery, I know that they're based out of King County, so they're technically in Bellevue, but they have a 12 to 17-year-old program that does accept Medicaid for their teen users. And for
Linda, do you have an answer?
Oh, well, it's not really an answer, it's more empathy. One of the things that I've seen happen over the last decade or more is that youth treatment has just diminished terribly in terms of resources. I know our legislature is trying to beat that up this time, but we have almost, Center for Human Services is about it, where even the inpatient centers, Sundown M Ranch is the last inpatient treatment center for youth, and it's just dying without a really good reason.
Surya, do you have a question?
Yes, thank you. Good evening. I'm Surya Pathak. I'm a professor in the School of Business and Nursing and Health Studies at University of Washington Bothell campus. And I have two questions. One, the first one is there any work being done on preventative measures beyond providing educational programs? I am conducting research on big data-based interventions, and this might be a question for Dr. Williams as well, and to some of the other organizations. Excellent work, but if I want to work with existing data, I have had a really difficult time accessing this information. So who are some of the partners that my team can reach out to work with? So the idea is, can we prevent some of these things to happen, instead of focusing on post-care, which is also super important, but we are interested in working on the time period leading up to addiction. So my questions are on those fronts. I would take any answer.
It's Michelle again from Evergreen Recovery Centers. As far as prevention, I don't know of any ongoing prevention. What I do know is that a large portion of patients with substance use disorders are coming from a history of childhood trauma and mental health issues, and prevention really has to start young, and it's a big can of worms, because we would need a lot of people to be involved with young children early on to really start taking care of this issue. It would be restructuring the way we look at everything. So I would love to see someone start taking that on. But it definitely, this disease starts in childhood usually.
Yeah, I think I'll echo that you're talking about non-specific prevention efforts. So any program out there that's designed to, you mentioned besides school, but even programs that are designed to promote school engagement, for example, will help with eventual drug use or preventing drug use. The Communities That Care program from the Social Development Research Group of the UW is an excellent resource. I've not applied it myself, that's not my job. But those sorts of programs that, again, it might not say that it prevents drug use, but anything that's going to develop stronger teenagers is going to be preventive in the long run. Now, if the question was aimed towards prevention for adults, in this country, we leave adults on their own, but obviously we already mentioned trauma-informed care, or just the idea of trauma. is certainly a start. You know, mental health care, et cetera, we know we have a problem. We know we have shortcomings there. So I think that there are definitely prevention programs aimed at children, mothers, you know, from an early age. All those things will help in the long run. But yeah, once you're an adult, you're on your own. As back to the data question, you're going to find yourself pretty frustrated trying to look for big data in this arena, because for multiple reasons. I can touch on them briefly, but the data sets don't correspond well. There's HIPAA issues. I wish I had more data. I wish every day that I had more data, and I just don't.
So if I were to, for example, share the work, we have been able to develop some really interesting insights, even with the very limited data we have scraped off the Washington Department of Health and the ADAI, whatever is publicly we could find. If I were to want to work with some of the organizations that are working with, is there a way for me to reach out to, for example, can I reach out to you, Dr. Williams, to share and discuss what might be possible?
Yeah, absolutely. Yep.
Thank you. Thank you. Thank you.
Thank you for your question and for everyone who participated in the answer. Claudia, do you have a question as well?
Yeah, thank you. I had a follow-up question about what Michelle was discussing about detox taking longer. I'm wondering, like, how much of a hurdle it's proving to be to get insurance companies to pay for more days, and if that is impacting people's recovery.
So far it hasn't been too problematic, as long as we can show that there's a medical need for them to be there. So that's where, you know, it gets tricky, because what we might consider a medical need in our field, our detox, may not be exactly what the insurance company sees as a medical need. So that does cause problems. We also, so the insurance companies have been paying for the most part, which is great. But we end up having a lot of people leave against medical advice, you know, towards day 4 or 5, because they're not feeling better either. So it's kind of a complicated piece just in getting, you know, having them complete detox. And of course, just going through detox is not, that's just very start. They need to follow up with some other form of treatment too.
Thank you. PBH, do you have a question as well?
Good evening. This is Vernetta Stewart. I work as a psychiatric nurse practitioner at Providence Hospital here in Everett. And thank you for the invitation of attending this meeting. I'm wondering about the needle exchange program. There was a statement as it can reduce overall overdose rates. Is that you're looking at the long-term perspective? How exactly does that help to prevent the rate of overdoses? Is it because you get people into treatment sooner and they're exposed to other resources, or what?
It's kind of a combination of everything. We are very generous on distributing naloxone, whether it be nasal or injectable, and being able to have the contact with our clients, that one-on-one connection, so that they know that we're available when they're ready to go to detox and they're ready to go to treatment. So obviously, the more people we can get down that path, you know, the less likely for overdoses. But, you know, with the rise in the fentanyl, you know, we're actually seeing less people injecting right now and more people smoking, you know, what they call the blues, so the fentanyl tablets. And so because we're seeing less people coming in for exchanging their syringes, we're really emphasizing going out there in the community and making contact with people in the encampments and on the streets and providing them that naloxone, because if we aren't seeing them to exchange, we're not able to provide them with you know, overdose kits and the resources to get them connected for treatment and other community resources. So it's kind of just a, you know, I like to look at it as like a community project, right? We're all working together so that we can connect people to all the different resources, and, you know, and it takes us all to be able to do that. I don't know if that helped answer that.
Yes, that enhanced my understanding. Thank
Perfect.
you.
Yeah.
Jim, it looks like we have a question in the chat. Let me see if I can find it.
I know, I'm looking at the answers here.
Therapeutic treatment with Suboxone, i.e. kind of explain more about induction, dosage, and adjustment for treatment with Suboxone was the question.
I can speak to that. So Suboxone is used as a tool in the recovery for opiate use disorder. It helps people manage cravings. It will mitigate withdrawal symptoms. There's not overdoses related to Suboxone unless other substances are being used, because it doesn't fully cover the opiate receptor. It doesn't take it fully over like some of the other opiates do. So it's pretty safe. And it can be used in a harm reduction way. It can be used, like I said, use as a tool to get people off of other opiates, or as an induction where they're staying on it until they're ready to come off of it. It's not like methadone where you have to go to a clinic every day and get your carry. We usually, here we will start people, if they do come into walk-in, we'll start them on Suboxone that day. Start them on Suboxone in detox, and they'll follow up with us for other services. And it's a great way to get people in the door too. For questions specifically about Suboxone, I'm happy to answer them. That was kind of brief.
Let's see. So Mira asked that question in chat. Mira, does that answer your question?
Thank you. What I'm looking at, is there what is the dose range for Suboxone? And does that vary with the individual? Does it vary with height and weight or age?
So it varies. It does vary, and the dose is generally 8 milligrams to 24 milligrams a day. Is if we're using Suboxone. There's other formulations of buprenorphine and naloxone that have different dosages, but it doesn't really matter about weight and age. It's more about use, how long they've been using, how much they've been using, and we dose. They get their dose will be based on if their cravings are met and if their withdrawal symptoms are mitigated. That's how we decide what is a good dose for them. So it may take a little bit of time to be on the right dose, because it's long acting, so it takes a little bit of time to build up in the body. We also offer supplicate or Suboxone injections here, which is a 30-day injectable buprenorphine, which it doesn't have the naloxone factor. And those are 2 different doses. They only come in a dose of 100 milligrams and 300 milligrams, but it takes away, it's very helpful for the patients. They don't have to worry about losing their medication. They don't have to worry about it getting stolen. They don't have to decide that morning if they're going to take it or not. It's in their body for 30 days, and even longer, actually. It stays in there longer, and it seems to be an easier way to eventually taper off of Suboxone as well.
And if I can pony on to that comment as well, the supplicate has also been really effective for a lot of the clean and sober housing for aftercare. A lot of places do not want to have MAT medications on the premises. So we're finding that that's a much easier way to introduce somebody to still being able to have the MAT services without actually physically having medications on site.
Supplicate is fully covered by Medicaid. So all the insurance companies that are managing Medicaid funds will pay for it 100%.
Thank you. I was totally unaware that there was injectable available, so that's good to know. Thank you.
Welcome. It's been a little bit of a game changer for us here. We've had success with most, I think, all but one patient has continued on it that we've started.
Great. Well, thank you very much for the question and for your answer. Commissioner Knudsen has her hand up. Dina, do you have a question?
Yes. I was wondering, because we were talking about the data and how you use the data to kind of, I was wondering how you gather the data, in particular around Snohomish County, how you determine where there are hot spots, and how do you decide where you're going to concentrate services, because Snohomish County is a huge county. But like when people are talking about teens or different groups, do you go to like community groups to try and get an idea of what the needs are? I'm trying to get some idea of how you gather up the information for how we make sure that the services are going where they need to go. And I was kind of looking at Jason Williams maybe as one of the people to ask, but also I would love to hear from both Evergreen and Sound. Okay, so yeah, that's my question.
I'll jump in on the overall data part, which is the shorter answer is the data I have in particular isn't going to be super helpful on citing services. There are delays. It takes a while to get death data in particular in, just for a variety of reasons. We don't necessarily have the geographic fine grain that you might like. So I think the answer is going to be you listen to your clients. And I have a feeling that that's what happened. And so I'll shut up now and let the people actually know, talk about it.
This is Shannon from the SSP. We do collect data that, specifically for the Verdant grant, and we look at different, I guess you want to say like kind of zip codes as to where they fall in. And we can see kind of areas where might have a little more activity. A lot of that is around the, the Linwood area, and then kind of the outskirts of that. One of the things that's hard for us is that we try to follow people in the encampments, and because they are continually being moved, it's hard to, we may be seeing some of the same people, but in a different location, and so we, keep data on our statistics that we come across. So I guess it just kind of varies as we kind of follow them as they go. And then so it's kind of that, that word of mouth. We listen to them and they tell us where, the places are that we need to go to really have our focus on. And I've been really working really hard to stay in connection with other businesses and other agencies that fall in that Verdant area, and making some connections even with like Edmonds College, some of the law enforcement agencies, and really building that rapport. The more that we can make those connections and build those relationships, the better we're going to get information. So as long as it's out there and it's not a secret and we're really trying to work together, the more information we're going to get to better serve our clients.
I think it's really important to follow, just a quick follow up, and this harkens back to, I think, the introduction to this whole presentation. It's really important to no longer think of opioids as an urban phenomenon. Right. It's all over, whether it's buying fentanyl off the dark web, right? The whole point about fentanyl is you can ship it really, one point about fentanyl is you can ship it really easily, right? So you can buy it off the internet, off of WeChat, whatever. It's really easy to distribute. And it's everywhere. It's not just in Everett. It's not just in Seattle. And actually meth is kind of the same way. Meth is spread to sort of non-traditional areas as well. So drug deaths, drug abuse is no longer just an urban phenomenon. It is all over. And so you do need to have your ear to the ground as far as where to cite your services.
Yeah, that's one of the reasons I was asking is because I know that in some of the programs at the UW, my son took some of the medical anthropology classes, and they were talking about interns that were interested in going out into communities and doing kind of a, not just a needs assessment, but actually like getting a sense of what was needed in different places. I'm wondering if that's a possible way of maybe supplementing what's already happening with the groups that we are funding as a possible, even through the community college for that matter, where we might, that seems to be one of the areas where it might be helpful to do outreach. So just thinking.
I can, I want to piggyback on that a little bit too, that, we are very open to having outside, we have some, interns that we work with now, and having outside agencies that want to come in and do like, go out in the community with us and do like, I guess you could say kind of like a ride along. We just had somebody from the Cocoon House going out with us. So, and that's another way to make those connections. When people say, I don't know what you do and what is your program about? And like, I'm always welcoming people, come into our office, come out with us. We have a process of how to, screen that and do that. So they get a better idea, and if they can then provide their resources that they have, for our clients as well.
Shannon and Jason, this was came out earlier today, so I'm putting you on the spot, but the survey data from all of the SSPs in the state of Washington was just presented earlier today. And Dr. Distelhorst and I were able to present that presentation. And one thing I found really interesting was the number of folks coming to SSPs who were coming to exchange for multiple people. So they reported that I'm here to exchange for myself, but also for 1 or 2 or 3 or more other people. So viewing that as a real opportunity to engage via word of mouth, and also tracking how far people were traveling to access those services at the county level. And I was trying to hone in on Snohomish County, but it does look like
I was just doing that myself as well.
Okay.
Yeah, on the map.
Yeah,
there.
so I think there are, Dina, to that question, right there are these opportunities of talking to current clients around, who are the other folks you're supporting, or you're getting Narcan for, or you're exchanging for, and kind of, where are they? What are they saying? So we can share that report. I think it's up on the website now, or will be soon.
Yeah. And just when you said that, it just reminded me, when we have clients that come in to see us, we try to say, hey, what areas do you frequent or whatever, we never ask where they're living, because some of them don't have, a set place. And so and then we provide them with our information for outreach, whether that be in Darrington or, we see all of Snohomish County. So we try to figure out and we never ask them oh, are these all your syringes? We always say, how many people do you need supplies for? And that gives us an idea, without putting them on the spot, as to maybe how many people they're going to be secondary exchanging with. So we kind of use those terms to not, shame. We don't want to make them feel, guilty about coming in. So we really try to connect with them to find out hey, here's our flyers. If you're, going to, or what areas do you think, somebody could use our services? And they're pretty good and pretty open. I mean, our place is a really comfortable and safe place to be. So they know they can offer that information.
I think the social network aspect of this is highly important, not just in the syringe exchange survey. And it's not the first year that we've done that. We've asked that question for the last several of these surveys, which we do every 2 years. And yeah, there's pretty high frequency of people collecting for multiple others. We also have some other data that we have in relation to a big naloxone rollout program that we did that involved people, when they refilled their naloxone, getting a survey at that point too. And so between the two, it's become really apparent that there are these networks out there, and that you often do have sort of one person for the network who is volunteered, voluntold, whatever, who's the person who goes and gets equipment for the whole group. You add to that in this survey in particular, the most recent syringe exchange survey, people were talking about the social aspects themselves. We actually asked about why people smoke, because it's more social. So you put all these things together. And so if you think of there being social groups out there, marginalized social groups, where one person might be the way into that group, right? So that one person might be your conduit for all your harm reduction messages, for your, hey, come in and get HIV tested, Hep C tested, all those health messages, flyers, whatever it takes. But just if you think about it, it's just one way to it's one leverage point to think about possibly exploiting.
I also wanted to add onto that is the looking at the new influx of peer support So you have the peers coming in that can bring you that information, being, maybe a little newer into recovery and being able to talk to the areas that they maybe came from. I know that that's been my personal experience, and that's how I've been able to get into a lot of places that maybe other people may not have. So the emergence of the peer support and the peer counselors is probably going to be a great opportunity for that as well.
Mm-hmm.
Good. Thank you very much. Linda, you have your hand up.
I just wanted to add that I was really responding to Commissioner Knudsen's question, that one of the things about trying to provide the services where they're needed is that, as we brought up, people do not follow through. Both the disease impacts that, and the challenges of a complex system also challenges. So one of the reasons we're particularly excited about this integration of physical health care into our addiction services is that we often see people with abscesses and wounds and co-occurring healthcare conditions that are not being treated, or when they are treated, they're being treated in a very expensive place, the ER, and quickly sent back out on the street. And so one of the things we're looking at from our angle is that it's good that we have integration in our physical health, but it usually consists of a screening of whether there's an alcohol or drug problem, and then maybe a referral, and then you lose them. So if we already see them in crisis, then if we can provide the healthcare services and the other things they need, that will be one barrier they don't have to cross, and maybe one more outcome that's better than sending them across the street to make acquaintance with somebody they don't know. And so I think it's the direction of healthcare in general. And unfortunately, the state took away our data system in 2016, and we don't have data, but I understand they're going to start collecting it in the not too distant future. Having that data just was a tremendous guide for me. This is my 50th year working in addiction treatment, started in alcoholism, and without data, it's very hard to steer. You don't know what you're really looking at. And so we have an absence of it, except in the program that both Sound Pathways and we have called Parent-Child Assistance Program, PCAP, where we work with moms who are addicted and their children, and we do a lot of preventive work there. And I wanted to mention that too, that we have tremendous services that we offer the children, both in our outpatients PCAP program and then in our pregnant and parenting moms program up in Everett, which is going to be growing. And we've also done some intensive work with the Harvard Brazelton Touchpoints program to bring better services to our moms when they're in alcohol and drug treatment. So our goal is to try to give the other services while they're there, get them enculturated and connected to the healthcare system, and then following through in a more responsible fashion when they go back out into the world as a person in recovery who's functioning better.
I want to thank everybody for answering, because you a lot of good thoughts and good ideas. And my experiences with people who have PTSD and that, who oftentimes use substances in order to self-medicate. So some of my, and I know a lot of times they're kind of hidden in the community. So yes, thank you very much. I really appreciate everything that you're doing.
I'm going to look at time, Jim. I know we're at time. And Thea, if you could pull back up that slide that had the contact information.
Okay, so there is Zoe's contact information. So it's 7:07 p.m. Boy, thank you for everyone for showing up and participating so actively, for your wonderful questions and perhaps even more wonderful answers. I really appreciate it. So I would like to adjourn this special meeting of the Board of Commissioners of Public Hospital District Number 2. Again, thank you all for coming and for participating. Really appreciate it. Good night.